Yes, first of all, I would like to say thank you so much for organizer, and especially Dr. John Word, that allow me to be here to share the experience from the Cambodia. Actually, Cambodia just to start this program early, around since November 2023. So the program just started. So we're still facing a lot of the issues related to the program. So today I just summarize our activity related to hepatitis elimination as the global goal to eliminate it 2030. But Cambodia may be still a challenge with the funding to support. So I just to summarize what we have done in Cambodia. So the content there is around the 16, but one point, maybe the one slide, I just summarize from what we have. So this global, maybe all of you aware about the burden of the disease in the global. So this slide I done the details, so you can see around 1.3 million people that die every year. So this is a report from the WHO 2022. So we cannot read, so you can see all the slide because of the timing. So this is the same. So I jump to the Cambodia country profile. Cambodia is small, so the population around 70 million, so the GDP around 24 the US per capita. So the latency 78.3 for male and the female. So the people mostly live in the rural area. So this for the health structure in Cambodia, we have for the national hospital, we had the 12, and the provincial, we have the 25 provincial hospital, and the operational district, we had the 103. For the referral hospital inside the operational district, we have the 94, and the commune level, that means we call health center, where we have around over 1,000. So this the national viral hepatitis elimination program journey. So we just to start from the MSF that had a project to screen for hepatitis C in Cambodia, but not B. So they start the small one pilot in the hospital in the capital in the city in the Phnom Penh. So that's in the 2016, but the small size. So this is the journey that Cambodia have. So after the MSF program, they finished in the 2020. So the small activity so still continue until the 2021 because the project of the MSF left from the Cambodia since 2021. So from the 2021 we don't have any activity. So the program just to start support funding by the government since the 2023. So the coverage of the site that we have started around the 15 sites, that means the 15 operational seats among the 6 provinces only, but not the cover in the whole province. So the one province we can cover only 2 operational seats among the 5 or 6, something like that. So from since the 2023 at November up to now, we cannot scaling up, so we still maintain the 15 sites. That means operational district that we can cover the hepatitis B and C. So this we have the document for the implementation of the program. So we had this national strategic plan for the viral hepatitis B and C infrastructure control in Cambodia. So and then we had the TWG, the member to discuss for any activity that we will do, and we have the guideline for the treatment of hepatitis B and C. But this document we start prepare since 2019. So this year we had the update. So we had the support from the friend initiative. So they will we do the review and then we will endorse for this year. So we will have a new one from the 2024 to the 2030. So this is the content of the national strategic plan for the viral hepatitis elimination program in Cambodia. We had the version, we had the goal, we had the strategy. So we had the 6 strategies. So I cannot detail for each the strategy. So it takes a long time. So this the Cambodia map, and then the coverage that the hepatitis B and C, the cover only the yellow side. So only if we look at the right hand side, we that I write the number, maybe that you can easier to understand. So the national hospital we had 12. So right now we have only 1 cover, and for the provincial health PAD, the main provincial health department, we had the 25. We have start the program only 7. So the provincial hospital we had 25. We have 6. So the right side that we have the cover by the national viral hepatitis program coverage. So in the bottom one we had the health center around the 1,200. So we just cover the 255. So the one more point that we try to find a way how to collaborate with another partner like the AEA. So we can say the Hepatitis Elimination Alliance. So this we work with the private clinic. So the NGO, they can support for the capacity building. So we invite all the private clinics to join us, and then our program to train them to use through our guideline to train and cure for the hepatitis. So you see in the map, so the white side, we don't have any activity. So this country contact epidemiology from the Cambodia, we estimate around 500,000 for hepatitis B and 183,000 for the hepatitis C. So the deaths caused by hepatitis B around 1,000 over, and the hepatitis C it's similar over the 1,000. So the hepatitis B, ABA antigen, the prevalent among the children under 5 years, 0.56. This is the survey from the university in Cambodia one. So the people living with the hepatitis B around 2%, and for the people the diagnostic around 24%. This data from the MSA. So the people can receive the treatment around the 39, and for the hepatitis C around 83. This is the data from the MSS. So the Cambodians try to make the easier and the simplify the model for the health worker that can use for the screen and treat the patient. So we had decentralized the service at the point of the care and close to the community. That means we can allow the health center that have the located in the community to start this program. So we have also the task-shifting so far we let the doctor, especially to use and the screen and treat the patient hepatitis B and C. But right now we can allow the health center screen and treat the patient that we found the infected hepatitis B and C. So we can integrate also with the existing programs such as the AIV and the NMCH and the NCD at the health point, the primary health of care. So this program we can let the health center to screen during the people come for the NCD program. So we can let them to start to screen the hepatitis B and C. So the simplified service is shortened to read the diagnostic and the treatment. Maybe we can do this way for the let the people can access the service. So this the HCV approach. So we can, right now Cambodia, we have the two ways for the health center. That means the located at the community. So at the second point, we use the referral hospital. So the many people to attend to start to the referral hospital for the OPD, something like that, for IPD, so we can screen also. From the health center, we start to use the rapid test or HCV, and then if we found the positive, we refer the patient to the referral hospital, because the referral we had the gene expert machine to use the cartridge for the gene expert to confirm material for the virus before we start. So if the result from the laboratory at the referral hospital, if we found the positive case of the hepatitis C, we send the information back to the health center, so the health center can start initiate DDA. So this way, and one way, and another way from at the health referral hospital. If the patient comes, we can screen also the rapid test hepatitis C. If we found the positive, we continue to do the viral load. If the viral load they confirm the virus, we start treat it the same. So hepatitis C may be easy to use at the grassroots level. So the hepatitis B approach, we do it the same, but right now Cambodia they follow the WHO guideline. If the health center screen the ABA antigen positive, we need to refer to the viral load at the referral hospital. But for the start of the treatment, so let the doctor decide it, because the doctor need to check with the hair, with the information related to the patient before we start the TDI. So this way we still not cover to the whole country yet. So maybe we still waiting the update the guideline, but maybe in the future we transfer the patient for the staff. That means after the doctor provide the TDF several months, maybe we can allow the health center to continue to provide the TDF, because the hepatitis B, we know we treat a long time, but the whole life, something like that. So this is the way that the Cambodia do. So this I just to share you the achievement from the hepatitis that we just to start since the 2023. So this number you can see that for the hepatitis C, we just to screen around 95,000 people, and then we found the positive around 4,000. So we start to continue to do the viral load around 3,000. So we found the positive around 1,000 over. So we can enroll for among the people that we found the positive from the viral load. So almost 100%. So hepatitis C may be easy to provide the treatment. So, and the green one, we just I just take the coverage from the January to June. So we just to screen around 30,000, and then we found the positive, like the number that I showed you, because we cannot read the whole the information in there. Maybe they take time a lot. So then, and the yellow side that we collaborate with the AA that I just informed you. So we collect information from the private clinic. So this number that I show. So the totally maybe we just to screen and treat for the people that infected hepatitis C around the 2,380. So the coverage may be the 99%, because some patient may be the delay to treat. So hepatitis B, the similar, but for the treatment, there's still the challenge. So for the treatment, still we have only the 73% among the people that we screened since the November 2023 up to the December 2024. So this the coverage that we have in Cambodia. So the totally for hepatitis B, we can provide the TDA around the 5,000. So the coverage we can calculate among the screening, among the positive, ABA positive, among the wild load test and the wild load confirmed. But this year maybe we need to separate the coverage from the wild load because the criteria of the treatment we divide we start from the virus over the 2,000 for the patient that infected the hepatitis B, something like that. So this is just a summary that we have achieved. So this slide I want to share you with MCHC, that means PMTC side, that we try to screen for among the pregnant women that attend the ANC first, that means ANC 1. So we are the target in the red, and then we cover just small because we have to start also in the 2024. So this PMTC side they have the fund support from the global fund, but not the whole country. So the commodity is still the challenge with the program, both the PMTC and the hepatitis program. So this number you see it is still smaller number. But at least we start our program from the 0.2, maybe in the future we can achieve. But if we have the fund to support, we can scaling up as soon as that we can do. So this related to the PMT side that we join all together. The PMT side they do for the skin and the hepatitis program. Also, we encourage the health center or the referral to screen among the pregnant women to attend the ANC because they have the target to eliminate by the 2030 through the global also because for the triple elimination HIV, syphilis, and hepatitis B. So this slide I want to share you the coverage of the immunization in Cambodia. For the hepatitis birth rate right now, we just to start in the 2008, so up to the 2024. So the coverage almost 98%. Because there's still the challenge with the remote area, especially in the mountains, so the people cannot access the hill facility because it's stay far, so sometimes they still delivery at home. But not more, but the mostly the coverage for immunization program is good because I worked there around over the almost 20 years. So this for hepatitis B, because we continue from the birth though, we still provide the pentavalent that had the 5 antigen of disease. So the mostly almost the 100% for the coverage. This slide I want the participant here to attend. I just to start. Cambodia we had the 28 prison. So I try to collaborate with the CSC, I mean the Catholic fund from the Australian, but not so much, it's too small. So we don't care how much we have, so we do. So I just to start early, the end of the August, in the 25 to the 29th day in the August. So we screen the prisoner. For hepatitis B, we screen only because the prisoner inside have only 171. So for hepatitis B, ABA antigen positive, we found 146. So if we calculate around the 7.8% of hepatitis B, but the C is the same number, but we found only 5, so they calculate 0.3%. So for the positive case, we continue to check the viral load to confirm before we start. So we collaborate with the prisoner and then with the CGHE that support for DRT. So We will provide the treatment to all the prisoners that are infected. They confirm the viral load. So if we look at the percentage of the hepatitis B is still high, more than the hepatitis C. So this slide I want to you to know about the funding support from the government. For the government, Cambodia commitment with the global to support, but the funding still a challenge because we have some issue in the country. From the COVID up to now, they had they complete the border from the Cambodia, Thailand, so they need to spend the funding to over there. So this we got the fund from the government since the 2023, 1 million. So among 1 million, we can purchase. See the number, I cannot read, so you can see in the screen. So this much. So when we finish that one, we nothing to do. So yes, this was in the 2023 and the 24. So right now we start to procure the 2025. But the commodity will arrive 2026. So the process it take a long time. So this is the number that you will consider on the commodity that the program hepatitis have. So we can do only this much, cannot scaling up in the whole country. Okay, so the lesson learned, I just to summarize, is the strong commitment from the leadership. So yes, we are very happy with the government that have the small fund, but they still consider for the hepatitis elimination. But we need to support from the partner. So the second point, we established the policy and strategy framework. So we already update. So this year we had a new one for the NSP guideline and for the report. But Cambodia is still a challenge with the data system. So the third point, we integrate diagnostic platform, integrate with the gene expert. Because the gene expert machine we use for the TB program that have the global fund to support, purchase the more and the cover in the whole country. But for the hepatitis, no, because we don't have, so we negotiate with the TB program to use the gene expert so we can provide the candidate so they can detect the viral load or the virus of hepatitis B and C. So the gene expert had the multifunction. They can detect every antigen like the COVID, something like that, flu, something like that. So yes, so the active, we had the stakeholder and the private provide the collaboration and the support. So the challenge, like I said, so the limit funding to support for that program. So we want to scale up to the 2030 in the whole country. So right now, if we calculate only the 15% among the whole country that we cover, so we still huge number that the people should assess the hepatitis B and C, because the hepatitis is the silent disease and may cause of the liver cancer. So the second point, you see among the 100, we just cover 1.5. So it's still the huge gap for the program. And then we cannot the scaling up capacity because we need to funding to build capacity. We think we cannot initiate the program without the trained health center or the health staff work at the referral hospital. So we need to more the funding to strengthening capacity building. So the program, we need the 2 points for the commodity and the capacity building. So this that we need, but we try to discuss with the partner like the China and Korea also, but not yet get fund from there. So the The number 4, the data system still right now we record on the logbook. So we need to upgrade to use the electronic, but we don't to fund to develop. But W try to do, but not yet finished yet. So maybe the next year, something like that. And number 5, we limit number of the stakeholder and the donor to support the program. And the last point for the low community awareness, we don't have any public to the whole country through the website, through any event, because we cannot provide the service for the people. If the people aware about the hepatitis, they come. We don't have any more for like the commodity, like drug, for sure, something like that. So the way forward, we want to scaling up hepatitis service through the government funding. So the 1 million, how much we can do, we do. If we have the more funding support from the partner, we can scaling up as soon as that we can. So we strengthening capacity, strengthening for the health worker capacity, and the third point for enhance the partnership and collaborate with the partner, include WHO, CHI, IPC. IPC, we start to pilot one for the screening for hepatitis C, for among the children from the 6 years old to under the 17 years old. Because our program we set up from the 18 years old, because the drug may be not available for the children, but we collaborate with the IVC to screen, but we had data, but I cannot show here because we take a long time. So from the result, from the pilot of the screening, the children among the infected hepatitis C may be the 100% also cure. So yeah, the CS that I just to say you, we will try find a way how to get the fund to screen at the prisoner, because there we found the more positive hepatitis B and C there. So number 4, we accelerate digital transforming, because we right now we use HRC to collect data. So the some may be the health workers still the entry wrong, or some they complete, some not complete, something like that. So we can we'll have the new, but when we finish, I don't know, but we try to talk more with the WHO to finish for we can say the CAM-EHR for the digital record, because we need to link with another system like the PMS2 that used by the Heritage Fund, something like that. So the last point, we need more funding to visualize through the donor partner, the government, to fulfill elimination target. So yes, the last one need more the multi-stakeholder engagement and the support. And so thank you so much for your attention.